Welcome. In this session we are going to start our discussion of the benign eyelid lesions, and we are going to describe them in two parts. In this session we are going to describe the inflammatory and the infective lesions, as well as the lesions originating from the epidermis of the skin and the sebaceous gland. There are a large number of benign eyelid lesions, and different eyelid lesions may have similar clinical appearance, and only histopathology helps us to accurately pinpoint the diagnosis. And since many of the lesions we will be discussing here originate from the skin of the eyelid, these lesions are also found in the rest of the body. Chalazion is an inflammatory lesion occurring from obstruction to the opening of a meibomian gland, and less commonly that of the gland of Zeiss. Both meibomian gland and gland of Zeiss are modified sebaceous glands. The secretions of these glands then accumulate, and this is followed by an inflammatory reaction to the contents of the gland. And chalazion usually presents as a chronic, firm, painless nodule in the tarsus and is histopathologically characterized by a lipogranulomatous inflammation. Sometimes it presents acutely with pain, erythema, and edema. In elderly patients, lid malignancy is an important differential, and chalazia can be recurrent in rosacea and chronic blepharitis. Chalazia can sometimes drain and disappear spontaneously, and an acute presentation of chalazion is treated with warm compress and eyelid hygiene. A chalazion in the chronic phase can be treated by incision and curettage or by intralesional steroids. Incision and curettage of a chalazion is done through a vertical incision made over the lesion on the palpebral conjunctiva. The incision is vertical so as to damage the minimum number of meibomian glands, which are also oriented vertically in the tarsus. For a chalazion involving the gland of Zeiss, which occurs more superficially near the eyelid margin, a skin incision is required, and that incision should be horizontal along the natural skin folds in this portion. Preferably the pseudocapsule of the chalazion should be excised, and atypical and recurrent lesions should be sent for histopathological examination, particularly in elderly individuals. Intralesional steroids are less effective than incision and curettage and can be combined with incision and curettage. Hordeolum is an acute, usually staphylococcal infection of the gland of Zeiss or mole, when it is called an external hordeolum or sty, or it can also involve the meibomian gland when it is called an internal hordeolum. So here we find a picture of a patient with external hordeolum or sty, and hordeolum, unlike chalazion, are painful and tender. External hordeolum, as we see here in this picture, localizes anteriorly through the skin and can be centered on an eyelash. However, internal hordeolum usually localizes posteriorly through the palpebral conjunctiva. Hordeolum can be associated with eyelid edema and can progress to preseptal cellulitis or abscess formation, and treatment of hordeolum includes warm compress and systemic antibiotics. In case of an external hordeolum centered on an eyelash, removal of that eyelash may facilitate drainage of the pus, and if an abscess forms, a surgical drainage of the pus is required. Molluscum contagiosum is caused by a pox virus, and the lesions appear as elevated, shiny, waxy nodules with a central umbilication as seen here with cheesy material. The lesions can be single or multiple, and in immunocompromised patients, the lesions occur bilaterally in clusters of 30 to 40 individual lesions, with the lesions being more confluent. Lesions near the eyelid margin can cause a follicular conjunctivitis. On histopathology, molluscum shows acanthosis, which is thickening of the stratum spinosum of the skin, as we will be describing shortly, with intracytoplasmic inclusions, and these inclusions appear more basophilic in the deeper layers and more eosinophilic in the superficial layers. Molluscum resolves on its own in 3 to 12 months' time, but can be excised or treated with cryotherapy. And in immunocompromised patients, hyperfocal cryotherapy to the individual lesions has been shown to be effective. Verruca vulgaris, or the common skin wart, is caused by human papilloma virus type 6 and 11, and it usually occurs in children and young adults. We find elevated lesions with a hyperkeratotic and corrugated surface, and lesions near the lid margin can cause papillary conjunctivitis. On histopathology, we find large vacuolated keratinocytes called chondrocytes with basophilic nuclei surrounded by a clear halo. Most of these lesions resolve spontaneously, and they can also be treated by excision or cryotherapy. However, incomplete excision can lead to recurrences. After discussing the inflammatory and the infective lesions of the eyelid, we now come to the other benign eyelid lesions, and we start with the epithelial lesions of the eyelid skin. And to understand the epithelial lesions, we need to know a few pathology terms related to the skin. In hyperkeratosis, there is thickening of the stratum corneum or the keratin layer of the skin, which is the most superficial layer of the skin. In parakeratosis, there is hyperkeratosis with retention of nuclei in the stratum corneum. Normally, before reaching the stratum corneum, the cells lose their nuclei. In acanthosis, there is thickening of the stratum spinosum or the squamous layer of the skin. The stratum spinosum is the layer immediately superficial to the basal layer of the epidermis. And in dyskeratosis, there is keratinization of the stratum spinosum, keratin or its precursors being restricted to the layer superficial to the stratum spinosum. Squamous papilloma is also called fibroepithelial polyp, acrocordon or skin tag, and it is the most common benign lesion of eyelids and is more frequent near the eyelid margin. They are flesh colored and can be either sessile or pedunculated. On histopathology, we find finger-like projections of dermis with fibrovascular core with hyperkeratosis and acanthosis of overlying epidermis. So we find hyperkeratosis and acanthosis of the epidermis and a core consisting of fibrovascular tissues originating from the dermis. Squamous papilloma can be removed by shave excision. Seborrheic keratosis, although called seborrheic, does not arise from the sebaceous glands but arises from the epidermis itself, and it tends to affect middle-aged to older adults. The lesions appear as single or multiple tan to brown colored greasy stuck-on plaques, frequently with a papillomatous surface. So typically they appear greasy and stuck to the skin. And seborrheic keratosis lesions in the eyelid may be more lobulated or pedunculated. It is not considered pre-malignant per se, but a sudden increase in size and number of seborrheic keratosis plaques can be a sign of occult internal malignancy, and this is called the sign of laser trelat. On histopathology, seborrheic keratosis plaques reveal hyperkeratosis, acanthosis and papillomatosis, and it can contain keratin-filled inclusion cysts called horn cysts and infoldings of the surface keratin called pseudohorn cysts. Seborrheic keratosis plaques can be removed by shave excision. Inverted follicular keratosis, also called basosquamous acanthoma, appear as hyperkeratotic papule or plaque, which is well demarcated, solitary, flesh-colored and papillomatous in appearance. And the lesion may appear inverted clinically. On histology, we find lobular acanthosis, and characteristically inverted follicular keratosis have squamous eddies, which are basal cells arranged in whorls, sometimes with peripheral acantholysis. Inverted follicular keratosis needs complete excision to prevent recurrence. Reactive changes of the epidermis occurs over another inflammatory, benign or malignant skin lesion, and two types of reactive epithelial changes are pseudoepitheliomatous hyperplasia, which clinically resemble squamous cell carcinoma, and cutaneous horn, which is characterized by an exuberant hyperkeratosis, and the base of a cutaneous horn requires biopsy to diagnose the underlying lesion. Epidermal inclusion cysts, also called sebaceous cysts, are epidermal in origin and not sebaceous in origin, and two types of epidermal inclusion cysts are described. The primary type, which arises from the infundibulum of a hair follicle after blockage of the surface opening of the hair follicle, and a secondary type resulting from traumatic implantation of the epidermal cells within the dermis. They appear as smooth nodules which are round, mobile, fluctuant and slow growing, often with a central core filled with keratin, and they do not contain sebum. Rupture of sebaceous cysts can cause inflammation of the surrounding skin. On histopathology, keratin-filled cysts are found which are lined by keratinized stratified squamous epithelium without adnexal appendages. Treatment requires excision with complete removal of the cyst wall to prevent recurrence. Milia are multiple and tiny epidermal inclusion cysts, but they do not have a central core. The primary type usually occurs in newborns and disappears spontaneously, and the secondary type can occur following trauma, infection, and radiation to the skin. On histopathology, we find dilated keratin-filled hair follicles compressing the adjacent sebaceous gland, and milia can be treated with topical retinoic acid. Pilar cysts or tricholemal cysts arise from hair follicles in regions where hair follicles are large and numerous, and in the pediocular region they usually occur near the eyebrows. They appear as a flesh-colored nodule which is smooth, firm, mobile and slow-growing, and on histology we find a keratin-filled cyst lined by epithelium containing basal epithelial cells, but the granular layer of the skin is absent, unlike an epidermal inclusion cyst where a granular layer is also found. Pilar cysts can calcify or rupture causing pain, and it can be inherited as an autosomal dominant trait. Now there are two epithelial lesions which are considered pre-malignant, and they are very important to remember. One is actinic keratosis and the other is keratoacanthoma. Actinic keratosis, also called solar or senile keratosis, is a pre-malignant lesion, and it occurs in elderly fair-skinned individuals with chronic sun exposure. The lesions appear round, scaly and keratotic with a sandpaper texture, and they usually occur in groups in sun-exposed areas of skin. With sun exposure, the lesions increase in number and darken and remit with reduced sun exposure. On histopathology, actinic keratosis shows hyperkeratosis, parakeratosis and dyskeratosis with atypical keratinocytes in deep epidermis forming buds extending into the dermis. The overall risk of developing squamous cell carcinoma is 10 to 20% in patients with actinic keratosis, and squamous cell carcinoma developing from actinic keratosis is supposed to have a better prognosis than squamous cell carcinoma arising de novo. Solitary actinic keratosis lesions can be removed with excisional biopsy, and diffuse lesions of actinic keratosis can be treated with topical 5-fluorouracil or imiquimod. Keratoacanthoma is a pre-malignant lesion occurring in middle-aged to elderly people and also in immunosuppressed patients, and it starts as a flesh-colored papule which rapidly develops over weeks into a dome-shaped nodule with a central keratin-filled crater and elevated roll margins. So we find a nodule with a central keratin-filled crater and elevated rolled margins. It occurs in sun-exposed areas and usually affects the lower eyelid. It can also have surrounding inflammation, and it typically undergoes spontaneous involution in 6 months' time, leaving an atrophic scar. On histopathology, keratoacanthoma shows a cup-shaped elevation of acanthotic squamous epithelium surrounding a central crater of keratin, and atypical cells may be present in the involved epithelium. Multiple keratoacanthomas can occur in Muir-Torch syndrome, and Muir-Torch syndrome is the occurrence of multiple sebaceous hyperplasia, sebaceous adenoma, keratoacanthoma and or basal cell carcinomas associated with visceral malignancy, and we'll see a photograph of a patient with Muir-Torch syndrome in a subsequent slide. Keratoacanthoma should be removed with excisional biopsy. Dermoid and epidermoid tumors are also epithelial in origin and can involve the lids, and they have been discussed in the session on congenital orbital disorders. After discussing the benign tumors arising from the epidermis of the eyelid skin, the next topic are the benign tumors arising from the adnexae of the eyelid. And adnexae are the structures located in the dermis and connecting with the skin surface through the epidermis, and the adnexal structures include the hair follicles, the oil glands and the sweat glands. The hair follicles in the eyelid skin are of two types, the eyelashes or the cilia, and vellus hairs which are similar to the vellus hairs found throughout the rest of the body. Oil glands are holocrine glands in that during the secretory process, the entire glandular cell is destroyed and the secretory product is then discharged into the excretory duct of the gland. And the oil glands present in the eyelid include meibomian glands in the tarsus whose ducts discharge the secretion in the eyelid margin, the glands of Zeiss whose ducts discharge the secretion in the hair follicle of the eyelashes, and like the rest of the body, sebaceous glands which discharge their secretion into the follicle of the vellus hairs. Sweat glands in the eyelid include the glands of Moll in the eyelid margin opening into the hair follicle, and they are apocrine in that during the secretory process, a portion of the cytoplasm of the cell near its apex gets detached from the remainder of the cell. The other sweat glands of the eyelid open directly onto the skin and are called acrine or merocrine glands because their secretory process involves exocytosis of the secretory product without loss of cytoplasm of the cell. And these acrine sweat glands are similar to the sweat glands present throughout the rest of the body. Benign sebaceous gland lesions include sebaceous hyperplasia and sebaceous adenoma, and sebaceous hyperplasia presents as multiple yellowish papules with a central core, and they occur in middle-aged patients. And on histopathology, sebaceous hyperplasia shows lobular hyperplasia of sebaceous glands. Sebaceous adenoma is an uncommon lesion occurring usually in elderly individuals and appear as solitary yellowish papules. And on histopathology, we find lobules lined with basal cells which become lipidized centrally. As we have discussed, sebaceous adenoma, sebaceous hyperplasia occurs in Muir-Torre syndrome along with keratoacanthoma and basal cell carcinoma associated with internal malignancy. Thank you for listening.